Bismillah ar-Rahman ar-Rahim. Thank you everyone that you have listened my lecture regarding assessment and management of the right eye and common eye emergencies. As you all know that it is a common thing that we examine many patients in our clinic as well as a GP. You notice that many patients come to your clinic and they're asking that my eye is red there, and even though in your sometime in your home your parent, your kids, your brother and sister, your relative, they have this problem, and yes, sometimes it's difficult that you send everyone to the eye specialist. Yes, being a doctor, you can treat this thing initially, and if it is not controlled by yourself, then you send us. And regarding this, my last talk, there is some queries, there is some question. I'm ready. I'm very happy to know that you people have listened my lecture and you have some queries, you have some questions, and inshallah, I'm ready to answer that question. The first question is that which antibiotic are commonly prescribed for bacterial conjunctivitis and a foreign body trauma? Previously we give, if any conjunctivitis, we give chlorophenol, and then we shift into optofloxacin, and now we try to give moxifloxacin antibiotic, and the commercial his name is moxifloxacin antibiotic. The dose is 4 times a day, and if you give a baby, you can give Ocumox eye ointment. It is better to give ointment in a baby. And if someone have a trauma, yes, you can give this antibiotic. The next question is about the chemical injury. In chemical injury, reepithelialization make cornea opaque. Does it get transparent afterward? If yes, then after how long? The thing is that if a patient come to you in acute stage, yes, there is a opaque cornea, but with the treatment, it can be transparent, and this is not for you. If you have any patient of this type of trauma, you should send to us, and then we can treat it. The third question is to assess the visual acuity of patient are Snellen chart and near vision testing cards sufficient at GP level for us to do. Yes, I think everyone know, being a doctor, everyone know how to check the visual acuity, because it's not necessary that you send everyone to us. If you see that anyone have complained that they have a problem in seeing, then you can check visual acuity by Snellen chart. And if you think that they have a problem, then you can send to us. The next question, in a patient with a red eye, what symptom and sign will help us consider that the cause is gonorrheal conjunctivitis, and what is the treatment? Look that in this question you are very specific about the gonorrheal conjunctivitis. Sometimes we miss, we ophthalmologists sometimes we miss. For that, I think the best thing is for you that you give this baby to some antibiotics, and if it is not cured within a couple of days, then you send to us, then we can treat, because it's not easy deal. Then you can treat this. What is the common cause of neonatal conjunctivitis? What should you treatment in such a case? Yes, I usually give some gram positive as well as a gram negative antibiotic. For that, I give moxifloxacin as well as tobramycin eye ointment. The next question is, what is the key points of difference in examining conjunctivitis, Claisian, and scleritis? Of course, in conjunctivitis there is a red eye, in Claisian it is no red eye, and scleritis there is a red eye. But in conjunctivitis, have a discharge as well as a red eye as well as, and sometime in bacterial conjunctivitis there is sticky of the lid. And in Claisian, it's a granulomatous inflammation of the meibomian gland. It is a chronic inflammation. There is no pain, and in scleritis there is a localized redness in some part of the sclera, and when you press it, you feel that patient has a pain. And then according to that, if someone have a scleritis, you send to us the patient. then we can treat that. The next question is, does viral conjunctivitis require some treatment as a viral keratitis? In viral conjunctivitis, usually it will be cured by itself, but to prevent secondary infection, we give some antibiotics. The another question is, can you tell us name of the some topical antihistamine and steroid drops to be used in allergic conjunctivitis? Yes, for topical antihistamine nowadays we are giving olopatadine. This the name is the company name is Ocudin, Zepatfort, and other company name is available like one is Ocudin, and other name is that Report Fort, Plow Fort. These are the name of antihistamine, and ingredient is olopatadine. And for the steroid is fluoromethalone FML, but I think it's not good for you people to prescribe steroid drop yourself, because sometimes you know that they have not only they have not only allergic conjunctivitis, might they have a corneal ulcer, and if you give the steroid, then it will be spread itself. It's better that if you think that someone have an allergic conjunctivitis, you give the antihistamine, but don't give steroid, because it can harm patient as well. As should red eye be managed at GP level, or when should we refer to a specialist? Yes, for red eye, yes, there are many causes. You people know that the red eye, one of the causes bacterial conjunctivitis or conjunctivitis. Another is can be a foreign body, can be a uveitis, can be acute glaucoma. Acute glaucoma. Yes, for or sometime allergy is one of the cause. Yes, for initially you can give antibiotics. If it will be cured in couple of days, it's okay. If you think that it will be not cured in couple of days, then you send to us. My another colleague have question is, kindly mention the doses of commonly used antibiotic in managing conjunctivitis and other causes of red eye, and dose of mannitol for angle closure glaucoma. My friend, that if you think that conjunctivitis is a severe conjunctivitis, you might give single drop too early, or you can give a 4 times in a day. As I discussed the other causes of red eye before, that they have allergic conjunctivitis, angle closure glaucoma, and uveitis, corneal ulcer. Regarding the dose of mannitol for angle closure glaucoma, yes, we give mannitol about 200 cc, but it's better if you think that anyone have a angle closure glaucoma, you can give the tablet AZM 250 mg 4 times a day, and then send to us, because it's difficult for you to manage the angle closure glaucoma. One thing that the question, my one friend asked, CT scan finding orbital cellulitis. My friend, that is if anyone have orbital cellulitis, it is emergency, and in emergency it's not good that you people write down CT scan for anyone, or it's not possible that you people treat orbital cellulitis, even though that a junior eye specialist, it's very difficult for him to treat orbital cellulitis. It's usually treated by the senior person, or the patient admitted in the hospital. Then there are multiple team involved in orbital cellulitis: ENT specialist, neurologist, and ophthalmologist. It's emergency. It's not good that I can tell you the finding and you can write a CT scan and then evaluate the patient, and then you can treat the patient. So if you think that they might have this problem, it's better to send to tertiary hospital. We already discussed about the neonatal conjunctivitis. Someone have asked again the same question. What is the difference between the next question is, what is the difference between the red eye and pink eye? Yes, the red eye, there are many causes. Pink eye usually have allergic eyes are the pink eye. If a patient come to us with a complaint of something went in the eye and there is redness and watering, discharge, how we proceed a general practitioner? Yes, when anyone have a bacterial or any type of conjunctivitis, they have a feeling that there is something in his eyes, redness and whitening. Yes, you can start antibiotics drops and look for a couple of days. And if it will be going better, if it will cure, is continue them, or otherwise you send to us. Because sometimes it happens that people think that it is only bacterial conjunctivitis. Sometimes it is punctate keratitis, and it is because of the viral. It need to examine the slit lamp, and it need to treat by the eye specialist. Every year a time comes with every other person is getting conjunctivitis. What precaution should be taken? How to treat it? This usually have a bacterial conjunctivitis, or it's usually we say ashobachism, and this usually occur in the month of summer, in when the summer weather comes. It's second, and it can be spread, and this is spread not by to sing to each other. It's spread by discharge. इसके बारे में थोड़ा सा मैं यहाँ बताता चलूँ कि तमाम लोगों को, न सिर्फ डॉक्टर्स और आम लोगों के लिए, कि ये एक तासुर दिया जाता है कि अगर किसी के आशुब चश्म हो तो उसको देखने से हमें भी लग जाएगा, या लोग काले रंग का चश्मा पहनने लगते हैं। ऐसा नहीं है। सिर्फ ये इसमें प्रॉब्लम ये है कि जो इसमें से डिस्चार्ज निकल रहा है था, जो मिक्स निकल रहा होता है, एंड इफ इट इज टच इन योर हैंड एंड टच टू अनदर हैंड्स एंड देन दे रब इन देयर आइज, देन इट कैन ट्रांसफर। इसके लिए इट्स बेटर टू प्रिवेंट दिस कंजक्टिवाइटिस, यू सेपरेट योर पिलो, यू सेपरेट योर टॉवल, you use tissue paper. And if someone have suffer in one family, there are chances that their families will involve these things. The next question is about the treatment of one body causing red eye. The thing is that of a foreign body is suppose sometimes foreign body is the feather of some bird, sometimes it is iron foreign body, and this you cannot treat the foreign body, okay, and for that you send us, and then when can we can remove, otherwise patient has more problems. The next question, please also tell us the treatment of sty ecclesion, as they are very common. As you know, sty is acute inflammation, and patient has a pain, and patient has a swelling. Yes, the best way is you give topical antibiotics, hot compression, and it will be cured. Don't need to give systemic antibiotic. But if it is sky, if it is Clasian, it's a chronic granular inflammation, and it need to incision and curate. It means it need to surgery, but sty you can treat. How to differentiate? The next question is how to differentiate clinically conjunctivitis and uveitis. It's very difficult to differentiate between both of them. Yes, clinically you can assess, or you can diagnose conjunctivitis. There are many signs and symptoms, but uveitis, for uveitis you need to slit lamp. You need to examine in slit lamp, and this can only examined by the eye specialist, because there are many signs like cells, flare, hypopyon, and you cannot see by the help of torch, and for that you need a slit lamp. The next question, please some name cyclopentolate drug used in uveitic patients. Yes, cyclopentolate or cyclopen, they come in the name of cyclopen, and it contains cyclopentolate. The next question is, please tell us what first aid can we give to patient who accidentally drops some alpha in eye and accidentally spray perfume in the eye. The first treatment or emergency treatment is to use or wash eye multiple times with copious water, and if you think that this alpha stick some part of the eyelid on his stick on the cornea, then refer to us, then we can remove it. And and the same time you wash and give some antibiotic drops. The next question is that what is the cause of retinal detachment? Can it be treated? There are multiple causes of retinal detachment, and like trauma, like myopic patient who have a more than 6 diopter of myopia, and they have a chances of retinal detachment because their peripheral retinal, the periphery of the retina is weak, and chances of retinal detachment is more. And other is trauma. And can it be treated? Yeah, of course. If a patient have this problem and they have lost their eyes, they come to us within a days. Yes, we do the surgery and they restore the vision. But if they will come after 1 year, then there is no chance. The next question asked by one of the doctor. They asked, how can we ease the post-herpetic neuralgia pain in the patient who had herpetic zoster of one eye 1 year back? Yes, in herpetic, the pain is present up to years, and for that we just give some painkiller. Otherwise, no way to relieve the pain. The next question asked by one of our doctors, and they asked that what sign and symptom do we see in diabetic retinopathy, and what prophylactic measure can be taken to avoid it apart from managing diabetes. Uh, you all people know that nowadays diabetic patient is present in every home. Our parent, our uncle, they have they are suffering in diabetics. One thing that keep in mind that if you have a very good control of diabetics, you delay the diabetic changes, but you cannot stop the diabetic changes. Another important thing that I want to tell you people that diabetes, if someone have a diabetes, diabetic changes in the eye occur rarely within a 5 year, but after 5 year there is chances of diabetic changes. If someone have not good control of diabetes, then chances of diabetic changes is more. And if you people have a ophthalmoscope and you people know how to examine a diabetic patients, and if people want that you want to train, we can train you. You come to us, and we give you some diabetic patient, and then you can see, and then you can learn that what is the sign that you pick, and then you refer to us. Of course, there is a dot hemorrhage, plot hemorrhage, continental spots, new vessels on the retina. There is a certain sign, and by this sign you identify, and then you refer to us, and when you refer to us, then we assist, and then we can treat. And yes, of course, if the patient come on time, we can treat and we can save the eyes. If a patient come in late, might they lost their eyes and no one can treat the eyes. The next question: what is the LASIK treatment? What is pros and cons? You know, this uh, LASIK is a treatment for anyone who wants to get rid of the glasses, and if and it's a safe treatment. Okay, and uh, I can tell you the pros and cons. Pros and cons. Of course, if someone wants to get rid of the glasses, this is the pros and cons. And the other thing that, of course, is it's a surgery. There are chances of some complications. Yes, patient have problem like dryness of the eyeball. Patient has difficulty in driving in the night. These are the most common complication. Otherwise, it is safe. The next question is that is our culture in our culture it is a common practice to put surma in eye. What are what we advise someone who not use? They say The sunnah and the sunnah they have is pure and homemade with no added chemical. How to proceed to such way? I always this is the common questions and this asked to us as well as many time patients. But if I usually refuse to everyone, but when I say and when I listen that is they use because of the sunnah, then I say okay, if it is sunnah, yes, of course it will be better for your eyes. And if someone have this practice, and if someone is using because of the sunnah, I say yeah, inshallah Allah will cure your eyes, Allah will save your eyes. But if it is not because of sunnah, then I say no, you won't use that sunnah. It is not effect on eye. The next question is: Can we differentiate different type of uveitis? GP, yes, no, we cannot. How do differentiate vernal conjunctivitis from bacterial conjunctivitis? In vernal conjunctivitis, it is allergy-related conjunctivitis. And one thing, the color of the vernal conjunctivitis, a muddy color eyes, and patient always has a redness, patient has a itching, and but in bacterial conjunctivitis, one thing that they have a discharge, but in vernal conjunctivitis, there will be no discharge. And vernal conjunctivitis, if someone have a vernal conjunctivitis, it can be continuing in their lives, and it's more common in the summer season, April to August, and bacterial conjunctivitis can be occur in any month of the year. If we get a patient whom we suspect acute glaucoma, then what initial measure we can give before suffering to us? Yes, you can give tablet AZM, acetazolamide, and then send to us. If a patient had corneal abrasion in past and treated, now want to wear contact lenses, what should we advise? Yes, they can, but it's better to send us, then we can decide they wear contact lenses or not. The next question: entropion seen in aged people who also causes repeated red eye. Is there a surgery treatment? Yes, entropion. The treatment of entropion is surgery, nothing else. An uncontrolled diabetes type 2 bacterial conjunctivitis treatable as easily or related to blood glucose level first? No, for any uncontrolled diabetes, yes, we can treat. What are the basic alarming symptoms on which he should be immediately referred to eye specialist and should not be treated? What are the basic alarming symptoms on which they should immediately refer to eye specialist and should not be treated by GP? Yes, if they have a patient with severe pain and you think that they might have a corneal ulcer, might have acute congestive glaucoma, you send to us. On which the patient should be immediately referred. As usual, steroid eye drop is relatively common in practice. So, what is the incidence of steroid-induced cataract in long term? Yes, if you give a steroid, yes, the chances of glaucoma is more. Infant and kids usually get watering eyes, so shall we prescribe any anti-allergic to them? If yes, then which one? Yes, if an infant have watering eyes, it's better to send us because the usually occur in infant of is usually occur because of the nasolacrimal duct block. And in nasolacrimal duct block, if someone have a nasolacrimal duct block, then it is necessary that we should tell to parent that you should massage properly within air. Otherwise, the next year they need to singeing probing, and if they will not do singeing, if they will not if a patient not treated by singeing and probing, then the last chance is this year. For that, I think if another thing that might someone have a ophthalmos and glaucoma. So if your kids have this thing, yes, you send to ophthalmologist. The next question: first aid to kid if they got hurt by any toy or any substances. Yes, you give some antibiotic ointment. Is conjunctivitis is continuous as precaution should be taken other family members? Yes, this is a conjunctivitis is continuous in bacterial conjunctivitis. What is the role of rose? What is the role of rose water? As a people says, it cures some eye element like conjunctivitis. If a girl is allergic or contact lens, but she is willing to wear at any cost, what should be the expense every time she must get rid of? One thing that there is no role of rose water, okay, and there will be no pure water, rose water, and it's not good to use the rose water. One thing. Another thing, if someone have using a contact lens and they have allergy, might they have a corneal ulcer, and if it is might a corneal ulcer, there is a very less chances to treat the corneal ulcer, and because of that, there is chances of lost sight. For that, I usually not allowed to anyone to wear the contact lenses. Can we prevent cataract to develop in old age? No, it's aging process. No one can stop it. Only Allah will stop it. Can prolonged use of steroid in eyes causing blindness? Yes. If any patient using a steroid prolonged, then chances of glaucoma, and glaucoma can lose the eyes. Can a GP remove a foreign body from one eye or refer the patient? No, you can't, because foreign body mostly stuck on the cornea, and we need to remove with the help of syringe. With the and you people cannot. You chance to can be you can puncture the cornea. It can be hit the lens. How to treat red eye causes by wearing of lenses? If anyone have using a lenses and they have a red eye, it's an emergency. An emergency must be sent to ophthalmologist, and sometime because of the contact lenses, they have a corneal ulcer, and if it is not treated promptly, then chances of the loss of the eyeball. What is vulnerable conjunctivitis? I already given the answers of the vulnerable conjunctivitis, that it is an autoimmune disease, and in which type 4 hypersensitization is involved, and it usually occur in the children. It will be continuing up to 16 years. The color of the eye is muddy color, and patient has a foreign body sensation, redness, watering, most common in the summer, and for that we give some steroid as well as some antihistamine drugs for many months. For how many days bacterial viral conjunctivitis remain continuous after we start antibiotic? Yes, for bacterial it can be a week until the discharge occurs. What are the causes of allergic conjunctivitis? Sometime of the dust, sometime of the pollens. These are the common causes. How can we treat keratitis caused by dry eye? Yeah, you cannot treat keratitis, because for keratitis we should examine by the slit lamp, and then we can treat. What is the posterior synechitis? Posterior synechitis means the iris stick on the lens is called posterior synechitis. How can we differentiate uveitis from conjunctivitis clinically? Conjunctivitis, yes, there is discharge, watering, redness, but uveitis, there is a discharge, but it's difficult for you people that you can differentiate between uveitis and conjunctivitis, because sometimes it's also difficult for us to differentiate both of them. What are the risk factors for orbital cellulitis, and how can we prevent it? Orbital risk factors, of course, there is the infections, and we cannot prevent it. Yeah, if someone have, yes, it's emergencies, and if you find anyone, then they have orbital cellulitis, you send to us, or as I told you that you send to some tertiary centers. If a patient develops cataract, glaucoma, or macular edema after untreated or incomplete keratitis, will that be treatable? Yes, we can treat. Yeah, so this will treat it, inshallah. Is there any role of intraocular steroid injection for treating UVS? Yes, there is a there is a role, but there are other treatment as well as. Yes, there is a how to differentiate if it's treated clinically. Yes, there is a difference. There is a difference clinically. There is a different way. In epistaxis, there is a localized, usually localized redness, and when press, it is a pain. And scleritis, there are different type of scleritis, and as I told you before that you people cannot differentiate both of them. As I told you that even though a junior eye specialist cannot differentiate between the epistaxis and scleritis. Should we diagnose viral conjunctivitis on exclusion criteria? It is not bacterial allergic, then it must be a viral or it is an criteria. There is some small history, sometime uh, examination can tell you something like in bacterial conjunctivitis, the best thing that you ask is there sticking of the lid, and if the patient tell you yes my lid is sticking in the morning, it means bacterial conjunctivitis. For an allergy, there is a no discharge. Okay, there is a redness, but there is no discharge. On for the viral, you can examine on a slit lamp, and when you use the fluorescein stain, they will be stained, and a specific type of a stain like a dendritic pattern, angiographical pattern, and then you can say this is a viral conjunctivitis. If a person is coming with a complaint of red eye and mild to moderate headache, then what should be our approach as a GP? Yes, if someone have a redness, you give antibiotics and check other causes of headaches. What is the role of warm compress in conjunctivitis? Yes, if there is warm compress, there is severe conjunctivitis and there is a chemosis, then you can warm compress. There is no role in compresses in conjunctivitis. What is the treatment of blepharitis in neonate and child? For blepharitis, we have a blephapred ointment. First, you clean the any thing on the lids. You clean that and then use the ointment. What is the role of hot and cold compression in disease? Hot compression, which usually we do in cases of style, and cold compression in cases of there is chemosis, then we can use the cold compression. The next question is, can allergic conjunctivitis improve with increased age? Yes, it will be increased. In in herpes zoster ophthalmicus, how to diagnose and treat the condition? By clinically, we diagnose and we treat. It's easy. Is it acid-retinal herpetic infection? Yes. How often a retina examination is recommended? Um, for kids, if around 6 to 7 year, 6 to 10 year, they come first, and if anyone have a more than 40 years, they come to examine in every year. Should we prescribe antibiotic in both acid and alkaline chemical? We don't need to give antibiotics. Okay. The next question is, when a patient with red eye come to a GP, we don't have tool to examine the eye except torch and visual acuity chart perhaps. So what should be our line of approach? How can we exclude corneal involvement? Yes, that's why I told many times that if anyone have a red eye, initially you give the antibiotic and then see if it will be better. Within a couple days, okay, you can continue. If anything it will be not continue, then you send to us, because there will be, as you are correct, that chances of corneal involvement as well as. The next question, what do you mean by grinding and drilling in the treatment? What do you mean by grinding and drilling in the treatment of? I don't know what are the drilling meaning of grinding and drilling. You have said in your lecture that viral conjunctivitis present in two ways seen by staining. Can you please explain again? It was not clear in lecture. And what is the treatment in both cases? In viral conjunctivitis, usually it will be treat itself, but if sometime we think that because of the super infection of the bacteria, we can give some antibiotics and it will be cured. The next question, if a high BP or stress has relation with conjunctival hemorrhages, what is the treatment? If someone have a distal conjunctival hemorrhage, it will be cured by itself. But if we say this thing to the patient, they are never ever satisfied. For that, I think it's better to give some antibiotics and tell him that it will take time. Sometimes it will take time 10 days, sometimes it will take 15 days. What will be the doses and duration of use of that broad spectrum antibiotics? Yes, you can give twice or thrice time in a day for 10 days. Kindly share 2 3 options that can be prescribed if the particular commonest one is not available. Uh, you can give octafloxacin, you can give moxifloxacin as well as, or you can give the tobramycin as well as. Which antiviral drugs are to be used in viral conjunctivitis? As I told you, we are not giving antiviral drugs in viral conjunctivitis. Thank you very much. You people listen my lecture and you ask many questions. I tried myself to answer all of the questions. And in the last, I want to tell you one thing that the good book for you people that you can read either Clinical Kansky or you can use Shafi Muhammad Jutoi or you can use Professor Shafiq Ali Beg books. These are the 3 books, and you can consult and then you can learn many new things. Thank you very much once again. In the end, I also thankful to the following trainee doctor for asking questions like Dr. Madhya Faizan, Dr. Shadi Ismail, Abida Nasir, Dr. Mahin Arif, Sadaf Noman, Dr. Mahira Fatma, Dr. Seema Salim, Dr. Saida Iman, Dr. Fatma Zafar Alam, Dr. Sadaf Amir, Dr. Shazia Javed, Dr. Nilofar Hassan, Dr. Mariam Iqbal, Dr. Talat Mustafa, Dr. Aisha Manzoor, Dr. Shabana Zinat, Dr. Sadia Sohail, Dr. Ambar Bano, Dr. Adiya Ahmed, Dr. Tuba Basir. Thank you very much for. This is the end of live question answer session for my lecture. If you still have more queries, please do consult from the books, and I have mentioned in earlier slide. Thank you very much once again. Bismillahirrahmanirrahim. My name is Professor Mazhar Hassan, and I'm the Professor of Ophthalmology, Dow International Medical College, Dow University of Health Sciences, Karachi. Today my topic of presentation is red eye. And you know this red eye is an emergency in ophthalmology, and today inshallah we will discuss you about etiology, treatment and diagnosis. Bismillahirrahmanirrahim. My name is Professor Dr. Mazhar Hassan. I am the in charge and Chairman Department of Ophthalmology, Dow International Medical College, Dow University of Health Sciences, Karachi. Today my topic of discussion is assessment and management of acute red eye. As you all know, this is an emergency. If anyone came with the red eye in eye department, then it's an emergency and we must exclude the causes, and then according to that we treat. It is the most common complaint in eye OPD. A red eye can be alarming, but mostly oftenly a sign of minor eye disease, but it could be a more serious problem than just a pink eye. As you know, the causes of the red eye is one is traumatic eye, the another is non-traumatic eye. The causes of non-traumatic eye is usually can be a conjunctivitis, can be a subconjunctival hemorrhage, uveitis, orbital and periorbital cellulitis, keratitis, acute angle closure glaucoma, stritis and episcleritis. Mainly patient come to us with the complaint of this red eye is the cause is conjunctivitis. Sometimes they are very worried when they have a blood in his subconjunctiva and they came in an emergency. The another cause of the red eye is traumatic, and the cause is obviously the cause is trauma. Corneal abrasion, corneal foreign body under eyelid, hyphema. Hyphema, you all know it's the blood in the anterior chamber. Because of the trauma, the blood came in the anterior chamber. The another is a chemical injury, corneal laceration and intraocular foreign body. When a patient comes to in our clinic with this complaint of either traumatic and non-traumatic, of course we should examine first, and according to that we prescribe we examine, we check his examine by torch, by the help of the slit lamp. We check the visual acuity, and then we see conjunctiva, we see cornea, we see any discharge like pus discharge, or we can ask about history about is the lid is sticking in the morning, and then we see is there any corneal defects, search for epithelial disruptions. And evaluation is very necessary, our history and examination. And when we do the visual acuity, of course we see the vision is normal or vision is decreased, because in some condition the vision is normal and in some condition the vision is decreased. Normally when a patient has a conjunctivitis, of course the vision is normal. When someone have a subconjunctival hemorrhage or pre-orbital cellulitis, the vision is normal. And if the vision is decreased, when we do the vision and the vision is decreased, it means the cause is trauma, keratitis, iritis, acute angle closure, glaucoma and orbital cellulitis. It means visual acuity is very necessary prior to treat the patients. If you look this slide, this showing there in the conjunctiva there is a red color inferior temporal and nasal part. Usually when a patient come with this complaint, when we see and we tell him that it is a subconjunctival hemorrhage, and the cause can be a trauma, can be a cough and sneezing, sometime because of the hot season, sometime patient has a raised blood hypertension. And the good thing that it will be absorbed themselves, and it take around 10 to 15 days. And we usually tell this thing to the patient that it won't hurt your vision, and it will be absorbed inshallah within 2 weeks. And you know, conjunctivitis is many type of conjunctivitis, like viral conjunctivitis, allergic and viral conjunctivitis. And the most common is a bacterial conjunctivitis, in which what happening that the patient, when they come to us with the complaint of red eye, yellow discharge, then the one thing is very important, you can ask that is the lid is sticking. If they say yes, the lid is sticking, it means the conjunctivitis is caused by bacterial. If there is a viral, or of course if there is a viral, then we do stain. And by staining we understand that there are two main type of viral conjunctivitis. There is two type, I'm not saying the two type, the two way they present, like dendritic wake or amoebic wake. Then you can say yes, it's the viral conjunctivitis. And the for allergy, yes, they give you a history of itching, foreign body, lacrimation, and when you examine you can see papillae and many other signs, and then you can label that it is allergic conjunctivitis. Yes, of course, if there is a bacterial conjunctivitis, we give antibiotic, and if it is If it is allergy, yes, we give some steroid and then we give some antihistamine, and for viral, we give antiviral drugs. Look, this slide is showing that keratitis, mean inflammation of the part of the cornea, then can cause be infection, can be mechanical trauma, and sometimes chemical injury like alkali injuries are worse than acid. Bacterial keratitis. When a patient comes with this problem, when we examine, we see that the red eye, purulent discharge, corneal opacity sometime, and have decreased vision, and sometime reaction and hypopyon. It's very difficult to treat bacterial keratitis, but we give some topical antibiotics which cover gram-positive and gram-negative bacteria. And prior to give this antibiotic, the best way to scrap and then culture and then stain, and then according to that we give antibiotics like fluoroquinolone, Bactrian, crefazine, amecin are indicated. And this slide, if you see that it is a viral keratitis, is mostly the herpes simplex and as well as the herpes zoster, and there is a if you see in the right side, there is a one slide is showing the dendritic pattern of keratitis, and then if you see the another picture which showing the at the scalp, it's showing the herpes zoster ophthalmicus. Of course, when anyone have this viral, then we can give the antiviral therapy, as well as we give acyclovir ointment with we give painkiller and painkiller, and sometimes we take opinion from the skin as well as. Uveitis is the inflammation of the iris, ciliary body and choroid, and we divide uveitis in anterior uveitis, intermediate and posterior uveitis, and it's alarming for anyone who have this problem. And when they come in our clinic, they complain of photophobia, red eye, decreased vision, pain, and there are many causes, and it's very difficult to diagnose why he has suffered this uveitis. And sometimes we write many investigation, and then we start treatment. And you see this is the sign of uveitis. In the one slide is showing the ciliary congestion, the another slide showing posterior synechial and epithelial, and then in the lower side they showing that KPs and hypopyon in the another slide. As I told you that the uveitis is the inflammation of iris, ciliary body and choroid, and for that we give cycloplegic drugs, cyclopine, to prevent the pain, or then we give as well as some steroid drops, as well as we give immunosuppressive medication. And the aim of this is to reduce the pain, and because these patients have developed glaucoma, cataract, and as well as macular edema. Acute angle closure glaucoma, it is an emergency in eye, and normally we don't have more emergency, but acute angle closure is an emergency in which what happened, that patient has their intraocular pressure is more than 45-50, but the normal, you people know that the normal intraocular pressure is 21 millimeter mercury, but because of the angle closure and people block, the pressure is raised up to 45-50, and patient has severe headache, pain, and when we examine that, they have a mid-dilated pupil, cloudy cornea, and a patient has facing nausea, vomiting. And if we will not treat, then chances of visual deterioration is more. For that we give some drugs, and sometimes we admit patient and we give oral acetazolamide, and we give IV mannitol 250 as well as glycerin sometime, and when the pressure is decreased up to 30-35, then we can add the beta blocker pilocarpine. And when the patient is stable, then we see their angle, if the angle, and in some cases we do laser peripherectomy. And if you look, this slide is showing the pre-orbital cellulitis, and it's usually occur in children, and in which the vision is normal but extraocular mode normal, but it's showing a little bit swelling of the lid, tenderness, fever, and we give systemic antibiotics, and we admit the patient and we give systemic antibiotic, and patient will be cured with the time. Orbital cellulitis is an emergency. Again, it is an emergency, and it's a life-threatening. It's not only the vision threatening; it's also a life-threatening condition. And when a patient come to us, of course they have a swelling on their lid, they have a proptosis, chemosis, and they cannot. It's very difficult to open their eyes, and the ocular movement is sometimes restricted. Patient has fever. And chances of it's also sometimes it's affect optic nerve, and for that, as I told you, that orbital cellulitis is an emergency. For that, we should admit this patient. We write some investigation like CT scan of the head, blood culture, and then we start same time antibiotics, systemic antibiotic, and sometimes we need surgical defibrillator. And if we will not treat on time, then there is chances of complication, and the complication can be meningitis, cavernous sinus thrombosis, and sometimes loss of the vision as well. Yes, episcleritis is also a red eye, and when anyone have examined, and then we see there is some redness as well as localized nodule, or sometimes it's diffuse nodules, and other things are normal, then yes, if it is inflammation, we give treatment, like we give topical NSAID, topical steroid, and it will be better in couple of days. Scleritis is again, it is inflammation of the sclera, and it is a more destructive disorder, usually occurring at the age of 20 to 40, and it has a pain but less as compared to the episcleritis. And there are different type of scleritis, some diffuse or nodular, and the treatment is of course we can give NSAID, indomethacin, painkiller, naproxen, as well as steroid, and cyclophosphamide, azethioprine, and cyclosporine. And if you look, this slide is showing the foreign body on the cornea, and if the foreign body on the cornea, of course patient have red eye, patient has irritation, they cannot close their eyes, and they come to us. And when we examine on slit lamp, yes, we can. And if you look in the another slide, it's showing the iron foreign body, and for that we put sometime local anesthetic drop, and then we take out the foreign body, and after that we give antibiotic drops. And this slide showing the chemical injury. It happened that someone have that chemical injury, and it is again emergency, and as soon as they come to us, before more asking the history, we start to treat the patient, and we irrigation with water, we start irrigation with water, and then treatment is depend upon the acid and calcari depend. And if you are not prompt treat, then it can lead to corneal opacification, melting, perforation, and severe glaucoma and late complications are. And if you this slide look that initially the patient come with the corneal abrasion, corneal sloughing, corneal cloudy, and in the later stage they become opacification and their new vascularization. As I told you before that it is emergency and immediate irrigation necessary, and simultaneously we give antibiotic, we give some cycloplegic drugs, and then it's going better if they come on time. As you know that red eye is emergency, and it's not only a bacterial conjunctivitis. Sometimes we think that is a bacterial conjunctivitis and we give antibiotic, but as you see this in this lecture, that the causes are many, like uveitis, corneal ulcer, acute congestive glaucoma, and foreign body. For that, if anyone have a red eye, they must come to eye specialist, and they examine timely, promptly, diagnose promptly, and then they start treatment. And sometime we save the eye as well. As if you will not come to us and you think that it is only a conjunctivitis and you treat by themselves, then chances sometime they lost their eyes. For that, I tell to everyone that if anyone have a red eye, you must visit to eye specialist. And when you come, of course, timely come, accurate diagnosis, appropriate referral when indicated, knowledge of each entities, make correct diagnosis, and treatment is likely. Thank you very much for giving your time. हो गया 20 मिनट के मेरे ख्याल में.